Gates Professor of Developing Societies in the Department of Economics and a senior fellow at the Brookings Institution. I became familiar with Dr. Kremer's work through our mutual friend Danielle and the chlorine dispensers that he'll be talking about today. And a lot of us have done work in various aspects of water, and what Danielle, who's spoken to our group before, has made very clear is that you can deliver clean water, but if you take home water in dirty containers or if it's stored improperly, what's the point of delivering perfect water? And that's where Dr. Kremer's work focuses, and that chlorination is a key and very fascinating way of keeping that water pure and delivering the benefits of clean water that is provided. So with that, thank you very much.
Great, thank you. I should say, to start with, that this paper will be a little bit of a hodgepodge of things and different topics, but I want to acknowledge a few people. It draws on a review article so it's going to be broader than chlorine dispensers, although I won't talk about that. I'm going to draw on a review article that I wrote with Alex Zwane and Amrita Ahuja, which looks at evidence from randomized trials on provision of water for domestic use in developing countries. So, are people here familiar with randomized trials, or should I say a little bit about that approach? And
I think in general, just a few general words.
Okay, great. So, there are a lot of issues. I think actually water is a great where it's very difficult to disentangle cause and effect, and to isolate the impact of a particular variable. So we know that people who have clean water, we know at some basic medical level that dirty water causes certain diseases. We know at some very aggregate level that we saw tremendous improvements in health in US cities, for example, after clean water and sanitation came in. But to know what's the impact, either whether we're talking about health impact or social or more social science issues, if you want to isolate what's the impact, say, what if you get the water without the sanitation, which is a very realistic situation. What if you get water, not perfect pipe water in your house, but say moving from walking to a well that's 20 minutes walk away to having a standpipe near your house? What's the impact of that in your health? What's the impact on your time use? You could compare people who have the well and who have the standpipe. You'll be picking up all sorts of other variables. Probably the people who have the standpipe, maybe they also have more political influence. That's why they were able to get a standpipe near them. Maybe if they have more political influence, they also have a better school, or they have other services from the government. And so disentangling the impact is very hard. It's also very important from either from a social science perspective or from a policymaker's perspective. Should you invest in bringing a standpipe, or should you say, look, unless we can get piped water to people's house with sanitation, there's really no point, we ought to put our money elsewhere. So there's actually, with some exceptions, which I'll talk about, there's only a limited amount of evidence, and so what doctors do in that is where they can, they do randomized trials, and that's, before a new drug is approved, there's a randomized trial to isolate the impact of that drug, the treatment group, the comparison group. There are some situations where we're starting to get some of that type of evidence in water and sanitation. Some areas where there's actually pretty good, but a lot of other questions where there's quite limited evidence. So we wrote a review article summarizing that evidence, but not focusing actually on the health impact, but focusing on some issues like willingness to pay, what's the impact of pricing on take-up and so on. So partly what I'd like to do is roughly the first half of the talk, I'll summarize some of the evidence from that, but I tried to adapt it to and cut out some of the more methodological topics and tried to think about water as a human right, which frankly, as an economist, we don't even have the concept of human rights. So I found it actually very interesting to start thinking about it that way. And then so that'll be the first half of the talk. And what I'm going to wind up concluding is that a lot of the things you would think about for thinking about water as a human right actually make a lot of sense when you're thinking about the safe water problem. I don't say they make sense. That's above my pay grade. Let me say the conclusions that you get from this, from what I would take as my amateur take on a human rights perspective on safe water issues, are actually quite similar to the ones that would come from several other perspectives. And there's sort of several different perspectives, analytically all separate, wind up with the same conclusion. And then I'll talk about ways of trying to trying to actually act on them, and that'll be the second part. Okay. So let me just, and so also in addition to thanking Rita and Alex on the review article, I want to thank Alexandra Fielder, who's provided some information, particularly on the dispensers part, which I'll talk about at the end. Okay. So let me start with the water and health problem, which I should say right off the bat is only a subset of the overall water problem. There are a lot of other water resource issues which are quite different. I'm going to focus on the water and health problem. So there are other water and health issues, but the biggest one is 1.6 million children are dying every year from diarrheal disease. It's 4,000 per day. It's 20% of child mortality. Unsafe water is a leading cause. And the world's political leaders coming together to develop the Millennium Development Goals, this was the sole quantifiable environmental target with a quantifiable target. And I think that's linked to the huge toll this takes. Obviously, there are other health problems from water. There's arsenic contamination, other things, but none of them have anything near the health toll that fecal contamination does. So how do you think about this? Well, a lot of thinking on water is driven what I would call the standard development paradigm. And the standard development paradigm is donors or governments are going to pay for the cost of putting the infrastructure, and then we're going to ask communities or user fees to pay for maintenance or any recurrent costs. And the problem is, how do we get people to pay? Okay? To maintain this. And that's a tricky problem. There's a lot of water infrastructure out there that isn't maintained. I decided to cut I'm not going to present the slides on that, but I have to talk about that a little bit later if people want. So that's one paradigm. And it's a very deeply entrenched paradigm. And I think it may make a lot of sense in certain contexts. So I think if we're talking about, say, irrigation water, that probably does make a lot of sense. Maybe it even makes sense for some domestic use contexts. Let me suggest three other perspectives. The first one, which I don't know a lot about but would love to learn, is human rights perspective, which I've learned epsilon about. But there's some international legal reasons to think that there may be some human rights to water. A second perspective is a health cost-effectiveness perspective. So this is something that is common in ministries of health and in, I guess, European health economics. Not very popular in America, but I actually wish it were a bit more, which is this is very straightforward. You find some way of quantifying the health gains. You look at the cost to the public sector typically. You divide, you get a cost per unit of health improvement, which could be diarrhea case averted, or could use something called a DALY metric, disability adjusted life year, which is controversial. It's a way of saying, well, how many, if we convert everything into years of life saved. It's controversial because it's, of course, lots of subjective judgments about 3 cases of blindness worth 1 year of life. That's very tricky. In this case, it's not so relevant because the DALYs from diarrhea, I'm going to be focusing on the lost life. And so the year of life would be the metric, which I guess philosophically is itself controversial, but we'll just, that's what you would need to, some measure of health gain, which I think is, not perfect, but I think is actually quite useful, rough and ready guide. Just for, it's a metric of comparison. In the US, $50,000, $100,000 per year of life is what health planners will sometimes use, as if it's cheaper than that, it's a pretty good buy. In developing countries, get figures like $150. Jeff Sachs or others sort of people want to spend more money would say, no, we should be using $500 or something like that. Okay, so huge gap in amount that societies are prepared to pay to save a year of life. But think at least $150, maybe $500 for poor countries. Third approach is this is the tradition that I'm coming from, which is public finance economics, which says there are sort of some, and I'll talk more about this later. There are certain clearly defined ground. This in general for private goods, let people decide how to spend their money. But for certain clearly defined reasons like externalities, there's a case for government intervention. And that's can be made more precise and more technical. I think what's quite striking, as I started to say before, is if I think about, my amateur version of the human rights case, there's a pretty strong, it's quite, even to a somewhat hard-nosed economist, the idea that a 3-year-old child should have a right not to drink fecally contaminated water, which could kill him or her, seems appealing as a human right. So I think there's a case for human rights, but economists are often extremely resistant to thinking about things in a human rights framework. I think the reason, to defend my profession, the reason we're often resistant to this is that there's in societies with very limited resources, that you have to face some trade-offs, because that same child maybe also has a right to an education, and maybe has a right to decent housing, and you can think of many other things that would seem as a right, and the society may not have the resources to provide all of these, so it may make sense to say, let's redistribute income to the household. The conventional approach of economists would say, let's redistribute income to the household, for example, like through a conditional cash transfer, which is done in Mexico and many other countries, and then leave it up to the household how they want to spend it. Let's not have the government say we're going to prioritize water over something else. So that would be the conventional economics approach. I think that I'm going to argue that there's a lot to recommend the human rights approach, and that you get quite similar results if we're thinking about the issue of water safety. We're thinking about the issue of water resources, irrigation water, or even, say, pipe water connections, convenient access to water. I'm much more sympathetic to the conventional economics approach. So these just tell you about I think the issue where a lot of the rubber hits the road is on the issue of pricing. If you have a human rights approach, you might say that that child has a right to this water, to safe water, and we shouldn't deny access to them by charging. Other people argue, and certainly the standard development paradigm is, you have to charge for the maybe not for the capital costs, but certainly for the recurrent costs for the maintenance and so on. So the advocates of charging will argue the poor can and do pay at least some fees. They pay for water. Urban poor pay more per liter of water than I do. The urban poor in developing countries, they buy from water vendors. Okay. They argue that if you charge, you might screen out low valuation uses. You avoid waste. That really the people who really need it will pay the most. Sometimes they argue, although this is they make an argument that, well, you only value something if you pay for it, so paying is going to get people to value it and use it better. And they also argue that fees are vital to sustainability and motivating providers. I think the critics are concerned about the impact on access and human rights. Often you get a compromise between these two groups, which is, well, we'll charge something, but we won't charge that much. There's a lot of slogans around this debate. There's often limited evidence. So let me, I think when you start to look at the evidence, and this is really one of the key things of our review article, it's very important to disaggregate water. I think water covers some very, very different things. So, very broadly, there's water resources. Do we have a water shortage? Lots of headlines about that. Are we going to have wars over water? So that could be for water for agriculture, for industry, for domestic use. And then there's the issue of domestic water, and you could split domestic water into ease of access. Do you have to walk 30 minutes to get your water from a well? Or is there a standpipe near your house, or is there actually a water connection? And the amount of water you'll use varies a lot with whether you have to walk 30 minutes for it. Then there's the issue of water safety. Okay, so this big split, and then within the split, we've got this one. If we're talking about water resources.
By safety, you mean clean water?
Clean water, right. So water resources, agriculture is by far the biggest user. And then there's industry and mining and so on. Domestic use is a very small proportion. Right? So if we're talking about water resources, we're talking about there's a limited amount of water, we have to allocate it. Then we're talking about, really, I think that is an issue where, I'm not going to claim there's no human rights element to that, but I think there's a very big scarce resources element which you have to allocate among competing uses, and maybe saying we're going to let people bid, quite sympathetic to saying, let's let people bid for water, and so it can flow to its highest value use, whether that's industry or agriculture, for example. you turn into domestic water, I think there's a lot of confusion that's caused by not separating out these two concepts. So, getting water closer to people is quite expensive. And it's particularly expensive in rural environments where the houses, the way that you would get the ideal access is piped water to somebody's house. That's very expensive, laying all that pipe, maintaining that, particularly in rural areas because people are dispersed, particularly in rural areas where people each live in their own house, each live on their own farm rather than concentrated together in villages, as in much of Africa. So this is a very expensive problem. You can also ask, well, are people willing to pay and what's the health impact? I'll come to those. This one of making sure the water's safe, everybody who's alive is getting some water. So there's nobody who's without access to water, but some people may have to walk an hour away to get the water and bring back 20 liters of water. Carrying that is not an easy task. So people incur huge costs to get the water, but nobody's surviving without the water. Making the water that they're getting safer is actually something that's quite cheap, as I'll discuss later. Now, you can draw these sort of theoretical distinctions. For any particular project, some of them serve multiple purposes. For example, I'm involved in a project looking at rainwater harvesting in central Kenya. That serves agricultural purposes. People use it to feed dairy cattle, and they also use it for hope. So there's certainly, in some policy issues, it's a mixed, they're mixed. But there's some investments that only affect some dimension. So for example, imagine somebody's relying on a well that's an hour away, and you come and you put in a well that's 10 minutes away. Well, they're going to be much better off, a lot better off, I think. But that wouldn't change the safety, wouldn't necessarily change the safety of the water. It would change how the access. Might wind up having a health impact if they use more water, wash their hands more. Okay. Other things, chlorination, that's not going to change the total amount of water people have at all, but it can have a health impact. It has a big health impact. Started to get at the differential cost of provision, but sinking a borehole, that can be, it varies a lot whether you're about where you're talking about it. In rural Africa, that can be $20,000. And maintaining it is expensive as well. Okay. Now I was surprised when I got into this field. I was looking for where the randomized trials on the impact of water. I just thought there'd be a lot of evidence on this. By the way, there's a big debate among the health professionals. Is it more important to get access to more water so you wash your hands more? We know washing your hands, good evidence washing your hands is quite important for health. Or is it more important to get clean water? And there's amazingly little, in my view, amazingly little hard evidence on the impact of greater access to water. We know that hand washing helps, but I cannot find any randomized trials until one that's been done very recently on what the impact is of greater access holding the quality of the water constant. There's a new paper by Devoto et al. This also includes Esther Duflo at MIT and others on Morocco, which I think is a good way of getting at holding quality constant. What's the impact of better access, at least in one setting? It's just one setting, so I don't think there's lots of reasons to think this could potentially vary across settings. So I don't want to draw too strong conclusions from this. Let me tell you about this study. It was urban Morocco. People already had some access to water, but they had to walk some distance to get it. Not far, but some distance. Then they brought household connections. They had to walk, they had to queue up at a standpipe. So the water, either way, was good water. It was high quality water. What did they find? So they found no health benefits. Did I even have that here? Okay. Anyway, there should have been a bullet point. No health benefits. It is on there somewhere. Good. They did find substantial non-health benefits. People saved time. They didn't have to spend all this time doing it. They spent, it wasn't they then worked a lot more. They had leisure, but they valued that leisure. They were happier. There was better social integration. They weren't getting into fights with their neighbors over their water. And people were willing to pay for this. In fact, I'll say more on that later, but okay. I think, I probably have covered some of this stuff before. Okay. And let me turn to making water safer. So let me review a couple of different studies from spring on making water safer. This is one I was involved in, which was spring protection. So this is an existing spring that looks something like this. This is Western Kenya. Kids but adults too, women mostly, but sometimes men, are scooping water out of this naturally occurring spring, and they bring it home. They put it in a big container, and then when they want water, they scoop some out with a mug and drink it. You can see that this is potentially, first the water coming out of there might be somewhat contaminated, and it's a spring rather than a stream, so it's going to be not the worst possible source. But if there's stormwater runoff, this will get contaminated. Also, when the kid's putting his hand in there, if he's got fecal matter in his hand, that water is going to get contaminated. So one approach, which is much cheaper than sinking a borehole wall, is to do something called protecting a spring. Obviously, this only works where there's natural occurring springs in the first place. You seal off the eye of the spring, you put the pipe there, some concrete, then the water is coming out like this. This costs only about $1,000. Okay? So that doesn't do anything to move the water closer to you. It doesn't make more water come out of the spring, but it does make it safer. So we evaluated a program like this, and so this was a randomized trial. So there are 184 springs. An NGO was going to protect all of them. They randomized the order in which they did it. We went and looked when some of them were protected and some weren't. We saw a 2/3 reduction in E. coli counts at the source, but only a 1/4 reduction at home. So what was going on? It was the recontamination that you discussed. When you take some water from your water pot, if your hand gets in the pot, then it can be recontaminated. Nonetheless, with this 1/4 reduction in E. coli counts, we also saw a 1/4 reduction in diarrhea. We were also able to look at the switching behavior. This is not an arid area. There's actually a lot of water sources in this area. So some people like to decide, am I going to walk to this? I could walk to a spring, which is over here. I could walk that direction and go to a stream and collect my water there. There's another spring over there. Which do I go to? We saw people switch sources. They moved towards these protected springs. They were willing to walk further. And we used an econometric model to estimate how much further were people willing to walk. And we found people willing to walk a few minutes more, but not very much. So there's a value of the we think willingness to walk as a measure of valuation. There was a value for this, but it wasn't a high value. Now, one area where there's actually a fair number of randomized trials is chlorination, and there's some also filtration, some other approaches to water treatment. There's a lot more solid evidence. So chlorination, there's review articles, there's enough papers, there's review articles like this, Arnold and Holford and Futrell and so on. 20-40% reduction in caregiver-reported diarrhea. Okay. There's some people who are concerned about caregiver reports. Is that a reliable source of data? I think there are some issues there, and more works would be useful, but I think there's plenty of reason to think that this is reducing diarrhea. There's also just the direct. We know that the chlorine kills the organism. So there's so this. Did you have a question or comment? No. Please jump in. That's our style of presentation, so I'm happy to do it.
I actually had a question on the previous slide where it said that there was 25. Can you go back to the previous slide and then I'll remember my question?
Yeah.
It looks as though there's less reduction at home, and that makes sense. But I thought it was the reverse, I guess. So basically, it gets less contaminated at the source, but then it gets more contaminated as you get.
Gets recontaminated when you
by
you've got
by the cup or by whatever it is.
Right. There's people keep their water. That's part of Kenya. People keep their water in big pottery jugs, and like this, this tall, and they do that. It keeps the water cool, and some people keep them covered, some don't. But even if it's covered, you have to when you take some water out of it.
And clearly, they didn't try adding chlorine to this system because then they might have been able to make it actually go up.
That's right. No, if you were adding chlorine, it could have been even. So that's actually chronologically my own history of involvement is first got involved in the spray protection project, and after seeing the results of that, and also after seeing when you go around Kenya, you see ads for small bottles of chlorine, which are socially marketed, and thought, hey, maybe this is a better approach because while there were improvements from cleaning up the source, you weren't getting possibly the full benefit. And also, $1,000 doesn't sound like a lot of money, and this is basically quite cost effective as long as you've got enough people using the source, but it's a significant sum. So chlorination, there's a lot of medical evidence that this works, okay? Chlorine is very, very cheap. So if you think about, this is a bottle of bleach. A bottle of bleach is enough to treat 70,000 liters of water. So what you buy at CVS. Now, I'm not recommending you treat with CVS bleach because for in bad enough circumstances, I would recommend that if the alternative were to get fecal contamination. But CVS bleach is not going to, the bleach you buy at CVS won't be precisely controlled levels of chlorine, and there are various other issues. But that just gives you a sense of, that's a $1 or $2.50 if it's on sale to treat 70,000 liters. Okay? So this is very cheap. The socially marketed chlorine sells for about 30 cents. So following what I'll call this sort of standard development model, that's very important to get users to pay for the recurrent costs. What is the approach that's being used in Kenya, 30 other countries, I believe, is NGOs are advertising these bottles of chlorine, small bottles of dilute chlorine solution, and they sell for about 30 cents for a month's supply. Okay. There's quite low use. So most countries are really 1 or 2% level. Zambia is higher. And in our area, very few people, less than 5%, something like that, would test positive for chlorine. So there's low adoption. So we've got a technology that potentially could be very effective, but it's not being used. So we started looking at why. One of the first things we looked at was price. And if this were a different type of seminar, I would give you 1,000 caveats to this. So there are some caveats. But basically, we said, let's test. What's the impact? Is it because people don't like the taste? Is it of the chlorine? We looked at adoption. This is adoption when this is 20 shillings, which is the socially marketed price, giving a subsidy, tiny boost in price. Okay? Paying, and by the way, even that 20 shilling price is probably subsidized to some extent. But I'm not said very heavily. But going down to 0, you get the majority of people adopted. Okay, not everybody, but the majority of people adopted. Okay? So price turns out to be quite important. Yeah?
Could you say a word though about the methodology in terms of just sample size and how you collected this?
So everything I'm presenting is randomized trials, and this is, I should remember the sample size, but this sort of effect, you don't need a very big sample size to detect significance. I think this was something like 20 springs in each treatment group, so 40 overall, and I forget, something like 15 people per spring. So think of 600-700 people, something like that. But what I think is more relevant is this one particular context. Okay? So I think I'm not too worried about the sample size issue for the big macro fact. The question is, does this generalize? Okay? So let me show you. This is a series of studies that are summarized by JPAL on what's the impact of charging for different preventative healthcare products. And if you look at this, you see a very consistent pattern that very small prices, price of 30 cents, 40 cents, 56, 60, 70, for things, not just for water disinfectant, but even for something like a bed net that could cost, that's worth $8 or something. They really reduce uptake. I should check this particular line. I think that may be anyway, I think there may be something special going on in that one. But in all the rest of these, you see a lot of people. I don't want to claim there's nobody who's going to buy at a positive price. So if you're a firm and you're selling to 20% of the market, great. You can make a lot of money. You can be a very successful firm selling to 20% of the market. If if you're an NGO and you're reaching 20% of the market, congratulations, that's great. And you're serving 20% of people who aren't getting the product. Might not be getting the product otherwise. But if you're a public health planner, or if you have a human rights perspective, your goal can't be to say, we're going to be satisfied with 20, 30%. You want to get much, much higher. And charging a price makes it difficult to do that for this type of preventative health product. Okay. So let me note the huge contrast here, which I think is a source of a lot of confusion. Understandable confusion. People say, how can you say the poor aren't willing to pay? The poor are paying. If you're living in an urban area, you've got to buy your water. People don't give it to you for free, and you're not getting it from a municipal supply. It's somebody who brings it to you on a cart or something like that, and you're paying a lot. Well, consumers are willing to pay for convenience. That was very clearly came out in this Devoto study. There's not a lot of willingness to pay for this preventative health benefit. And let me be clear, I'm not making some sort of moral judgment. This is something that shows up in developed countries just as well. A small barrier to something that's a preventive health investment can be huge. And we all, I just had how many of these chocolates? I'm not optimizing my long-run health. I don't take an aspirin every day, which I guess I should. People are, so this fact just keeps coming up empirically, time after time. Okay, so for quality, whether it was spring protection, chlorine treatment, or other studies, and that suggests that if you want to get water quality improvements, you may need to subsidize this. Now, what about things to try to, so a lot of NGOs put a lot of effort into shifting the demand curve, or what economists would call shifting the demand curve, trying to, which you could call raising awareness or other things. And we looked at not we, but a bunch of, including me, but many other people have looked at different ways of doing this. And what you find is that there are some things that work, but you're not going to see those dramatic jumps from sort of less than 10% to the majority of people using this. At least not in the randomized trials that exist now. Okay, so if you do something like do a test, there's some tests that you can do that very dramatically illustrate to people that their water is fecally contaminated and bad smells come off, etc. Well, that worked, but it's expensive to do those, to send around a field worker to do those tests at each place. Probably more expensive than actually supplying the chlorine. There's some interesting findings. It's not just a matter of information, at least not the way that rational information processing, let me put it that way. Doing communal, another set of things that came out is communal versus individual persuasion. There's some evidence community-based messaging works better, and that personal contact helps a lot. Yes?
What is a course message?
Yeah, sorry, that's from my economics jargon-filled presentation that survived into this presentation. So I think this is fascinating. It just sort of shows that we economists understand better.
Neither do us non-economists.
So this is from arsenic in Bangladesh. The government, they found out arsenic was a problem. The government went around, tested the wells for arsenic. If it was above a threshold, they painted the well red. If it was below, they painted it green, so people could know which wells were safer and which ones weren't. So some economists came along and said, well, they used an arbitrary threshold for painting the wells red or green. It was 50 parts per billion. I don't know. That's you can see on the science I'm not so strong. So they said we don't really know, and I trust them on this. 55 parts per billion versus 45. You had to draw the line somewhere. Wouldn't it be better to give people more continuous information? So that, for example, imagine all the wells around you are red, but some of them are 60 parts per billion and some are 500 parts per billion. Well, maybe you want to switch to the 60, or maybe some of them are 40 and some of them are 10. They're all green, but you want to go to the one that's 10. So they thought, we'll give people what's finer information. Divide it up, and instead of divide it up into just this coarse red or green, divide up, the exact numerical count. And they thought this would help. And what they found out is that people were less responsive. Why? Because this is basically not something, people have a lot of problems. They have a lot to worry about. So worrying about, so that's, I think, the real lesson from, one of the methodological lessons from this work is the importance of what economists are now recognizing across the board, the importance of psychology and economics. It's called behavioral economics. Which is, you can't count on people perfectly optimizing and say, well, I know that chlorine is good for health and therefore I'm going to buy it even though it's 30 cents because the health benefits would outweigh that, or I'm going to, a simple, or this is 247 parts per billion, this other one is only 172, I'm going to use the 172. A simple message, red, green, actually did better.
Thanks.
Okay? There's also this big communal effect. So making things, having personal contact with somebody who's promoting this actually makes a big difference. We didn't find much difference in the content of the message. And so we tried various things about messages about modernity, messages about being a good mother. It didn't really make much difference. Okay. So let me come back to these different different perspectives. Okay, so I'll leave it to others here who to say more about the human rights perspective. But I think there's a sort of a prima facie case for human rights, case for some what would be basic needs, which would probably include not fecally contaminated water. Might also include not walking an hour to collect water. Okay. What about health cost effectiveness? Okay. That's something that that we cover a bit in our review article. So here, we actually have surprisingly little data on the health impact of closer access to water. I think there's this Devoto study which doesn't find much, but that's one context we need more. So I would say we need more data. There's quite plausible channels, particularly if you can make the tie to greater hand washing. People, I don't think whether you live far or close is going to affect how much you drink. That's a small part of even domestic water consumption. But hand washing can be very important. What about water treatment? Well, when you work out the costs, and this requires some assumptions, you find that the estimated cost per year of life saved is very, very low. In other words, providing basic water treatment, whether it's chlorine or there's some other approaches, but chlorine is probably the cheapest. Very, very cost effective relative to other health expenditures. I wrote $100, but $60 less. So it would be worth it if you're a health planner, if you're a Ministry of Health, then we're going to take some of our budget and move some of it towards treating water. Okay. What about a public finance perspective? So this is the tradition that I would come from. This one says, let's let individuals make their own decisions. Maybe we redistribute income, but we don't interfere in whether they spend their money on rice or maize. That's their decision. Except if they're under certain rationales. And one of those rationales, well, the first one is externalities. That is, if what I'm doing affects my neighbor, so pollution is a classic example. Infectious disease is another example. Government subsidized vaccination. Why? Because if I get vaccinated, that doesn't just help me, it helps my neighbor. If we think about these two things, water infrastructure to bring water closer to people, and water treatment. Well, water treatment, if we're reducing my diarrhea, that's going to reduce diarrhea for other people. It's going to reduce the spread of whatever it is, cholera or other diseases. So there's at least a prima facie case for public subsidies there. Another concern would be distributional issues within the household. So if you just say, look, it's up to the household to decide whether they want to spend their money on wheat or rice, well, but what if that's not, and we should just redistribute between households. That doesn't work if you're concerned about distribution within the household. Water is an issue where there are definite distribution issues within the household. So women often have to do the work of collecting the water. So they bear the cost of water collection, typically, and children. And children, the people who die of diarrhea are young children, so 3-year-olds. Okay? One question you can ask is, how does willingness to pay vary by the number of 3-year-olds in the house? Okay? If you're concerned about, if the household were rationally maximizing health, they would be much more likely to use chlorine or to pay for chlorine or to walk to get to a protected spring if there are more 3-year-olds in the house, because they're the ones who are going to die. The healthy adult who has a healthy immune system isn't going to, they might get sick, but they probably got a lot of immunity. we see almost no change in willingness to walk or willingness to pay based on the number of 3-year-olds. In other words, that suggests there's very, very low valuation of the additional health benefits for this population. That could be a lack of knowledge, could be a lot of factors, could be behavioral biases. People at some abstract level want to do it, but they have trouble actually doing it in the moment, just like eating these candies or not taking aspirins. But suggests these distributional issues are quite real. Third one is behavioral biases in decision making. Fourth one is public goods, non-rivalry. When there's a good that benefits many people in the community, and the other people using the good doesn't reduce the extent to which I can use it. So if you look at that spring, that's an example of non-rivalrous water infrastructure. Any number of people, I mean, I guess if eventually we get crowded and congested, but in rural Kenya, there was no, in this part of rural Kenya, there weren't long lines of that. More people can use it. So there's a case, the marginal cost of using it is zero. There's a case for a public subsidy. I won't go through details on this, but if you think about these, for each one of these, there's a strong, let me start with these three, there's a very strong case for subsidizing treatment of water. Okay? This fourth one may provide a certain case for certain types of water, bringing certain types of water infrastructure closer, like a well. Okay? So quantifying this, it's not enough to just say they're there. Quantifying is important. So you can weigh the size of these effects against the cost.
Can you give an example of a behavioral bias?
Yeah, sure. Let me give you I'll give you an example. The example I just gave, I'll refer back to that. So if people were perfectly rationally processing information, the continuous information would be better than the coarse information.
Okay.
People have limited information capacity at any one moment, then they might prefer the coarse information. Okay? So it's you can think of this as departures from full rationality. Another one is present bias, where given the time, I probably should move on to the rest of the course, but basically, people put a lot of value on something today versus tomorrow, often. That's not, economists used to model this as just consistent discounting, 5% a year, 10% a year. It turns out that's not actually the way people are. People discount a lot between today and tomorrow. Discounting between 10 years from now and 10 years and a day from now, they don't discount very much. And that means you'd like to commit your future self, if you will, to think more about the future. And let me keep going here, though. Okay. All of these. So these factors are going to make a case for treatment. I think, unfortunately, my last slides are a little bit out of order. I'm going to try and speed up. Let me sort of switch gears, given that we've only got half an hour left. I think we need more research on the impact of water quantity, but we do know that water quality has major health benefits. It's very low cost, but there's very low willingness to pay for it. There's a strong case in terms of either human rights, or in terms of health cost effectiveness, or in terms of sort of the orthodox economics of what's a public good and what's not a public good for subsidies. So and it looks like practically we're going to need those subsidies if we're going to get access available not just to 20 or 30% of people, but to the majority of people in the poorest countries, access to safe water. So what do you do about it? Okay, so that's yes, so let me sort of shift into the second part of the talk, which is,
Just
let me
before
pause.
go
I'm sorry,
ahead,
I'm gonna take time process to comment.
when you mentioned the low willingness to pay
Yeah.
for the better quality, what was the main causes for this unwillingness or low willingness within this community?
Yeah. So I think, I don't think we fully know. I think that there's a combination of factors. I don't think it was that people didn't understand there was a link between water and disease. We asked people, what are the causes of diarrhea? They would list dirty water as one of them. But that's not the same as sort of knowing the precise details of the medical relationship. This is a hard, you can be drinking chlorinated water and get diarrhea. There can be flies, there's fecal matter, there's lots of other ways you can get diarrhea. And obviously you can be drinking dirty water and not get diarrhea. So it's difficult it's not something people have perfect information about. There's also, I think, this present bias. If you're thinking about certain health behaviors that you have to do over and over again, we don't necessarily do those out of full rational calculations each period. Gets into the behavioral issues I was talking about. I think there are things where you got into a habit where it's automatic. So a lot of things that we make automatic. So for example, that's why we have airbags, so we don't have to count on putting on a seatbelt, because some people didn't put on seatbelts. It's also easier if it's close to automatic, if not totally automatic. You can make it as convenient as possible. So there, I think those are some of the factors. Okay? Yeah.
Yeah, quick question. So in economics, it's possible to do randomized controlled trials in certain micro situations, but not on the macro economy. This means the relationship between the micro and the macro is not a priori causal in either direction. Instead, it would be some kind of statistical correlation or inference. So because of that fundamental flaw with macroeconomics, I would argue the human rights might be a stronger argument for the public subsidies.
So I think what's interesting to me is that all of these approaches seem to be pointing to the in the same direction, at least in the case of safe water, water treatment. I think that they would give somewhat different analysis for some water access issues, but for the water treatment, they seem to be pointing in the same direction. And maybe you're right. Maybe it is a stronger case, though. Okay. Were there other comments? Or? Yeah.
Did you look at all, or just notice how people were using energy or fuel, and how that impacted on their finances and on their health? Going to get wood, maybe a lot of people cook. That may be a health benefit in that some of that food would be, less contaminated. But also it's reducing the quality of water if trees are coming down.
Right.
That's maybe a bigger calculation, but were there any choices people were making as far as paying for kerosene or whatever they...
Oh, there's a whole other... People definitely have energy problems and issues, so their firewood is getting scarce. People have to go further for it. People are buying charcoal, which is being brought in from elsewhere, which is causing deforestation elsewhere. They're cooking with... There's a lot of indoor air pollution, which is also a huge killer because of the way they're getting their cooking fuel. So I think there are a lot of energy issues, and there's actually some water-energy intersection, because I don't think most people do this, but some people are boiling their water to try and deal with the contamination, and some people are drinking tea or other things, which is effectively another way of dealing with this. And then you've got the indoor air pollution, you've got the firewood use, and carbon. So there are some important intersections, but that wasn't the focus of it. I haven't done research on those issues, and I haven't even reviewed the research on that. So where do you go from this conclusion? Because it's a real paradox. There's the thing that people are willing to pay for, where you don't have the demonstrated health benefit. There's the thing that does have the demonstrated health benefit, and does have the stronger human rights case, and does have the sort of classic economic externalities case, and the classic and the maybe newer economic behavioral economics case, but you don't have a lot of willingness to pay. So what do you do? Well, let me talk about a couple of approaches. How would you get take-up to increase? Well, I think making it free, making it either automatic or, if not, as convenient and salient as possible. Trying to harness social norms. Remember, there's this community effect. So what are some alternatives? Well, one is piped water. So that's ideal. That's going to be best for health. That's better than, I think, anything else. Treated piped water. That can be very expensive. There you have to, if you're taking a human rights approach, you have to take a phrase I just learned of progressive realization. You're not going to be able to attain it all at once in a place, Africa or much of South Asia. Another approach is point-of-use treatment, or coupons for point-of-use treatment. So you could provide. My slides are a little bit imperfect here. You could provide this so the people who are dying from dirty water are kids. So you could say when kids come for immunization, or when kids are born, they get some supply of dilute chlorine solution, or they get coupons for dilute chlorine solution. The problem is the dilute chlorine solution is only stable for a certain amount of time. So giving a full supply is a little bit tricky. And if you give coupons, what we found was take-up is very high initially, but then it tails off. People don't necessarily redeem all the coupons. So I think that would be good. I think part of the solution would be, providing coupons for dilute chlorine and coupons for dilute chlorine and clinics. And it's not very expensive. What I'd like to talk about more is point of collection and treatment options. So this is an approach that we tested in Kenya, and that an NGO called Innovations for Poverty Action is currently working on scaling up. So these are dispenser full of that same dilute chlorine solution. It's located at a communal water source. When you turn the valve, I should have brought one with me, that releases enough chlorine to treat 20 liters, which is the standard collection container. This container has enough chlorine to treat 20,000 liters of water. The local promoters, so the system is, I wouldn't think of it just a dispenser, it's a system. It's a dispenser, it's a local promoter who refills it, they get the chlorine supplied to them and they refill it, and they maintain the dispenser so that it doesn't really require much maintenance, and they promote use in the community, at least initially. They get paid for 6 months, a couple of dollars, Alexandra, was it a couple of dollars of,
That's not on a t-shirt.
yeah. So they get a token payment just for 6 months. So it's not sort of a temporary short-run effect. This is sort of an effect that seems to be persistent. The majority of people using it. Not everybody using it. So maybe there's some people for whom the taste is a barrier. If you can get to piped water, that's better. Or if you could get to, yeah.
The promoter is stopped promoting it, but there's someone replenishing it all.
Right, so there's somebody delivering chlorine to the promoter, and the promoter, who typically lives, next to the water source, is got to refill it. So they're doing that as a volunteer, basically. Yeah.
Just a question, in terms of when so you have 6 months, the promoter's being paid. When was that data collected? How far was the promoter still being paid when the?
No, this is at 18 months, and they were just paid for 6 months. Yeah. And we've now collected that gone out to 30 months, and basically it stays. It went down a little bit, but still the majority of people using. I think the function didn't go down statistically significantly. So you can start to calculate cost effectiveness. And I told you that the packaging is actually those little bottles of chlorine. It's actually the packaging is more expensive than chlorine. So this approach is actually cheaper to deliver to a big container like that than it is to deliver these bottles to individual households. So this is the number of diarrhea cases avoided by spending $1,000. Okay? And so hand washing promotion with free soap in Pakistan. This is JPAL's calculations. Free home delivery of chlorine, encasing water sources. So that picture that I showed earlier. These are all these are good investments. But what free home delivery of chlorine, and then here's the chlorine dispensers at the water source. So this is what by far saves the most cases of diarrhea per $1,000. And if you want to translate that into a cost per deli, and these are estimates, here's an estimate of $25 or something with a chlorine dispenser. The cost per deli starts to get quite a lot higher when you're talking about all of these technologies. Distributing chlorine and other approaches also looks very good. When you get into some of these other things, it gets more expensive. But it's, I think it's important not just to compare this to other water interventions, but if you thought about, say, HIV treatment, that would be like $500 per deli or something. And when the medicine itself is much cheaper, but if you take into all the accounts of providing HIV treatment, so this is very cost effective. It's comparable to vaccines. So, how are you going to finance this? So here's an approach that can get high take-up at pretty low cost, but how do you finance it? Well, I should say IPA has been experimenting with various approaches. So one approach, the Ministry of Education has bought some dispensers for schools, and and then it's had private distribution, so people go to a chemist shop from the school, a pharmacy, or CVS, let me say this, the Kenyon equivalent of CVS, although it's not a chain, to pick up the chlorine. That was one approach. Another approach, and this was paid for by the Ministry of Education, another approach that some local governments did is they contracted with IPA and they said, we'll pay for you to put in a dispenser and deliver the chlorine, and we'll give you a contract to do that. That's working very well. This one, there's some problems with the teachers picking up from the chemist shop. You could also bundle this with water provision. So if I said there's not a lot of willingness to pay for safer water, but if you're already paying for water to be delivered, not necessarily safe water, the extra cost of making that safe is quite low. So in some cases, bundling those two things together can work quite well. Or you can bundle with other services. So there's an NGO called 1 Acre Fund, which is basically an agriculture NGO, but they've decided they also want to address some health issues, and so they're bundling this together. So there's a bunch of programs in Kenya. There's right now about 420,000 people who are have access to chlorine through dispensers in Kenya. We're piloting in Haiti. There's about 100 dispensers there now. Think of, I don't know, 10, 15,000 people with access. Okay, let me just, this is maintenance in general, not about dispensers in particular, not about dispensers at all, actually. These are, what would be ongoing sources of finance for this? Well, one approach is governments, including local governments, and that's what IPA has historically invested most of its energy on. And basically the finding is governments are willing to pay. There are various different parts of the government in Kenya, local governments, different ministries of the national government, but so far they've been buying at limited scale. They've been buying dispensers and chlorine at limited scale, which means that the cost, there's economies of scale in distribution. If you're delivering this, one thing we found is very important to deliver. You can't count on people to come pick up. You have to deliver the chlorine. And if you're delivering to, if there's a district, the way politicians tend to look at things is, I've got to spread this out. I've got 15 districts, and I've got to make sure each one gets 3 chlorine dispensers. Then that tends to be very high cost of delivery. What you really want to do is blanket an area to minimize the delivery costs, and that's getting enough market through government purchases. Maybe it would be successful, particularly as local governments get more power and more bigger budgets, which is happening in Kenya. But that's a route that I think is still promising, but is a lot of work. Okay, there's endowments, which is, if you think about somebody building a well and putting in 20,000, quite typical. That's the maintenance slides I skipped over. Quite typical for donors to spend $20,000 sinking a borehole, not to invest in maintenance, to count on the community to do that, and then the well will be broken 3 or 4 years later. And that's a very common problem. I think if they instead said, we're going to put in a dispenser which costs $40, and we're going to allocate $5 a year for maintenance, not maintenance, for refilling the chlorine, and then we're going to set aside, we're just going to endow a big enough fund to support this for 20 years. You get more, you can put in 10 dispensers or 20 dispensers for every, at existing water sites, rather than trying to dig new ones. The final approach, which we're just starting to learn about, is carbon credits. So there's a private firm which has developed a filter, which is distributing that and the filter, and then getting credits for because of the reduction in need for boiling, and therefore the reduction in need for carbon emissions from biomass, from fuel oil, or from corn cobs or so on. I think there's some people who are, including me, who have some concerns about the technical features of the filter that they've got. But I think this approach of, and there are other potential concerns about how they're accounting for this, very serious concerns. But I don't want to get into that. I haven't studied that, and I'm not really prepared to discuss that. But that is, I want to flag it as a potential source for funding for something like this. And at least some preliminary calculations we've done suggest that because chlorine is so cheap, this could more than cover the costs. This alone could more than cover the costs of the program. So just conclude by saying, I think realizing a right to safe water, something that economists, I'm sort of professionally trained not to like that phrase, but nonetheless, I've been brought around by the data. I think this is something that is quite feasible. And I think if we're talking about the limited category of safe water, as opposed to everybody having piped water or something like that, then this is something that actually could be accomplished, and we don't really have, even poor countries could afford to do this, even out of, set aside anything exotic like carbon credits, simply out of the government budgets. This would be a trivial fraction of the government budget and would be a very good health expenditure. How to do that, how to implement that, is going to require addressing a host of practical issues. How do you handle the financing of this? How do you handle delivery? You have to set up delivery systems. Also, the chlorine gets delivered. That's not an easy thing to do. I'm talking about chlorine. This could, there are other technologies out there. So I think that is, and there's some places where chlorine is inappropriate, et cetera. So, but I think the general point is this is something that we can do, not just in a sense of progressive realization, but with the existing budgets, there are enough funds to address the core issue of, honestly, arsenic contamination and so on. But the issue that's helping kill 1.6 million children a year, we can do that. And we can do financially, we can do that now. And the challenge is to find out feasible ways to do that. Thanks.
Looks like we have about 15-20 minutes for questions. And actually, last night when I was reading your article, I don't want to point out the fact that you are arguing for human rights, but when you use the word low weight, which is in the article for those who had a chance to read it, those who are unempowered and disenfranchised, the people that we believe human right to water goes to, is exactly the people that you're pointing to are the ones who need help in public service and population. So it's amazing how many crossovers there are between the things. So. Sure.
So one question is actually just thinking a little bit beyond chlorine.
Mm-hmm.
And having looked at some of the literature and spoken with some people that do household water treatment, knowing that the issue of uptake is huge. And if you look at the range of household water treatments, whether you're talking about ceramic filters to the life straw to chlorine, to what, and you said that there's not tremendous amounts of information, academically sound information out there. So if you are thinking about, if you're a donor agency, for example, and you're thinking about how should you be perhaps guiding a government in terms of thinking about how do you scale this up? Is the first step to be doing some kind of research on the ground and trying to assess whether you're in Indonesia or a different part of Africa or India or Latin America to assess what's being used and go through a few years of actually seeing what's the uptake and what are all the behavioral concerns, and only from there making the recommendation? Because it seems like there is a lot of funding that is going to these various pilot projects around the world, but without having the real sustained uptake, because people will get products and then not use them.
So I think that there's some geographic heterogeneity here and some cultural heterogeneity. So there's some. So let me start with the case. So let me talk about the issue of evidence first. So one area where there is actually fairly good evidence is on different water treatment technologies. So filtration, there's a fair amount of evidence on that as well. So there are some places where in Kenya, I think for the majority, we're only getting the majority of people using it. We're not getting 90% of people using it. So maybe for those remaining people, it's a taste barrier, or maybe it's just a barrier of getting people to change their behavior isn't easy. I think there's I think a bunch of the products that are out there have very low uptake, and they have predictably low uptake because they require a lot of behavior change. Let me give the example of solar disinfection. I hate to pick on that, but I will. You have to get the water. I mean, people are not willing to do a lot for preventative health behavior. Or I don't want to say people. There's a large proportion of populations around the world who are not doing the things that are best for their health, and things that require effort every day, like solar disinfection would have, taking some water, putting it up on your roof and waiting several hours for it to get disinfected in a special bag and then bringing it down. So I think approaches that require as little behavior change as possible. Piped water obviously being the extreme. I would say second to that is I don't have to rank them all. I think that might be culturally specific. So I think finding some pre-testing, not necessarily to measure health impact, because I think health impact's fairly well understood for a range of treatment technologies, but to understand, knowing what uptake will be. Some places you can do that with existing data. In 30 countries, this is being socially marketed. You have some evidence on it. Haiti is another place where there's high uptake. Don't work in Bangladesh, where I think taste may be more of a barrier. Certainly, Danielle Antain, who some of you know, would say culturally that's going to be a bigger barrier in Bangladesh. So there you may want to go with filters. I haven't put up the charts for filters. I think they'd be a higher cost per galley. My guess is that they would still be okay. How many people would use the filter? I don't know. So you'd want, if it hasn't been piloted, you'd want some data on use rates. One nice thing about chlorine from a scientific perspective is you can actually test whether people are using it because you can test the water and see if there's chlorine residual in it. It's harder with some of these other things. But of course, I think in a lot of contexts, so a lot of the deaths are in Africa, South Asia is another big place. I think in a lot, certainly East and Southern Africa, chlorine seems reasonably acceptable. West Africa, we need to learn more. I think there's room for, certainly it would make sense to pilot any of these programs before going full speed ahead. But I don't think you need full-scale health. I think further health testing is warranted, which should proceed in parallel. I think we already have pretty strong evidence that boiling, or by the way, I haven't talked much about boiling. In Indonesia, people boil already. That's great. I mean, it's not great for energy and some other things, but it's great for health. Let's not mess with it, you know. But in places where water isn't already being treated by a substantial fraction of the population, I think piloting is necessary for these logistical takeout feasibility issues. Maybe more work is needed on the health, but I don't think that should stop us from rolling out, basically. Sorry if that's a long-winded answer.
Yeah, so have you thought already about combining some of your different recommendations? For example, with Sanergy in Kenya, we're in talks with Safaricom to offer users extra free cell phone minutes to harness their behavioral economics impulses if they comply with certain health, sanitation, hygiene measures, and then see if the government will help support this initiative with Safaricom. And you could try something like that. So you combine behavioral economics, bundling other services, government support.
I think there's certainly a role for trying to try some of those things to lift that take-up rate from, somewhat above 50% to see if you can get that towards, 70 or 80%. I think there's a lot to further to do on that.
In the back?
Yeah, you touched on kind of a Malthusian aspect of the kind of consumptive human rights when you talked about if we provide clean water as a human right to individuals, they'll then maybe survive to consume and have a right to consume nutrition, education, and things like that. So I questioned if as an economist, kind of a macroeconomics aspect, if you looked at that at all, if you looked at that.
Oh, I'm sorry, I didn't mean to be Malthusian about it at all. I just meant if it costs $20,000 to put in a borehole and the village doesn't has to walk, people in this area have to walk for a borehole to get their water, then on the one hand, maybe they have a human right not to walk 45 minutes to get their water. On the other hand, that $20,000 could also build a school and maybe they have the right to education, so you have to make trade-offs. And I think those trade-offs are much smaller ones when you're talking about water treatment than when you're talking about moving the water point closer.
One of the things that I know has been a barrier in the communities we work in Zambia has been, if we give them a relatively small bottle of water, and then the cap is designed so that it measures the amount that they're supposed to put in a 20-liter container. But it's also designed so that the taste won't be bad.
Right.
And what we found is that people don't believe that they put enough in
Yeah.
to protect themselves.
Yeah.
And so then they put in too much.
Yeah.
And then the taste is bad.
Yeah.
And so then and that's how the thing would drop off.
Yeah.
Usage would drop off.
Yeah.
So the advantage of your system, or the system you showed there, is that everybody uses the same amount, and they see their neighbors and friends using that amount, and apparently, and hopefully they've been, the promoter has convinced them that there's less diarrhea as a result. And then over the 6-month period, and so then they get into the habit of doing it, and they don't see a lot of diarrhea happening in their neighbors and stuff, so they just keep using it because it's a good habit that they've gotten used to. So I think that there's a really positive thing there. But as you said, you didn't look at comparing it to filters to see whether there's what the differences are in terms of the take-home.
Yeah, I think the first point you mentioned is a good one, and let me just add to it that there's more imprecision when you're trying to fill a cat full, and it's easier to put in too little or too much, and that can
waste it.
And there's wastage, right?
Yeah.
Right, exactly. And on the filters point, no, we haven't looked at filters. I think in this particular environment, one of the filter will get the water clean, but won't prevent recontamination.
Yeah.
So in this particular environment, I think chlorine makes sense. Most people are willing to deal with the taste, but some other environment, filters might be the best way to go.
There are some studies on filters. I'm sure a lot of people are aware that one of the big problems is people aren't willing to wait for the time. And that's so
Yes.
then it just ends up being a shelf in the house.
And there's some technical aspects to it too. If they don't use it, if they don't use it for a while, then the filter becomes ineffective.
How do we reconcile some of the observations that you were pointing to that were the results from Morocco that seem to imply that people are willing to pay quite a bit of money for the convenience of water closer to their homes? On the one hand, with some of the observations for, I guess, Kenya that you were making when you were saying that it's very typical for boreholes or wells to be built inside of villages, but after a few years they're not kept up and then they kind of die off. If we just extrapolate the Moroccan case, you'd assume that everybody in the village would be willing to pitch in enough, a little bit of money to fix the well in the village if they were behaving the way the Moroccan's business. Or no?
So I think it's a public goods problem. It's worth it to each individual, but everybody else would rather have somebody else contribute, and it's just hard to organize the system to. I think one of the things Kenya is doing, if you think about the U.S., this is often handled by local governments, which don't sort of go around with their hand out saying, it's actually good for us all if we have a water system. Will you contribute? No, they tax you,
Right.
or they say if you want to get supply of water, any supply of water, you have to pay this rate. So that's local governments in Kenya historically have very limited power and very limited budgets. There's a constitutional reform to give them the much more budget and much more power, and have locally elected governments at the municipal county level, which right now there's just a national government, and if you're the national water minister, you're going to put your effort into getting more boreholes sunk in your part of the country, rather than trying to put money into maintenance all over the country. So I think it's political and institutional failures that are preventing, the willingness to pay, which I think exists for the convenience, from translating into maintained infrastructure.
So hypothetically, you think if a small private company or something were to fix a well and charge people a bit more for the water, do you think in the McKinney case, do you think that might work? Regardless of the questions of whether companies would do that or not, do you think people would actually be willing to do that?
So I think a lot depends on the context there. If you're talking about sinking so I think in most cases, no, to be honest. And let me say a little bit more why. That was part of our first paper. Most rural cases, no. That doesn't mean that it's not a bad business to go in, because you don't need to serve 100% of the market. If an NGO serves 5% of the market, that's a tremendous success, but relative to 0% right now. So most of these waters, this particular area of Kenya, has a lot of those springs that I showed you. Those are not built by anybody. Those are available and they're free, and people are used to them being free. And there's the only I don't think people would be willing to pay a lot in this particular rural area to get borehole water that was closer. There are some cases when they would, and they would do that as the economy grows and people get a little bit richer. I think they'd be increasingly willing to. In urban areas, there's a much denser market. So if you're sitting around waiting for customers all day because there's only 20 families that are using this because you're in a spread out rural area, I think it's very hard to make a business work. In an urban area, it's a totally different situation. There, especially as you move slightly up the income ladder to slightly richer countries, then certainly it's possible. So there are some efforts in India that I think sometimes you have to read some of these claims with a little bit of skepticism, but there's some people in India who are water kiosks are making money, and certainly Indonesia that's happening. So some places there's a market for it, and I think it'd be great to pursue that, but you have to be realistic about where it's going to work and where it's not going to.
Kenya is one of the countries that Charles and I are working on our program, and they last year instituted a human right to water in their constitution, which includes access to safe water. So they're very much engaged in that. Several of the officials sent over to Stockholm this year. So just an aside, they're very much involved in that. So something very open.
I'm interested in the value of information. When you talked about sort of community information providing versus private, and then in your paper you talked about surveys and how they can influence. And just as a practitioner, thinking practically, is there value in having someone, even an outsider, go back to a place, say once or twice a year, and sort of doing that kind of family survey? I wasn't quite clear.
It's very expensive. So that's I'm more into having somebody local do it on a very low paid semi-volunteer basis. So that's what we're doing on the dispenser project. And I think, anytime you're talking about, at least in rural Africa, if you're talking about sending an NGO worker from the district capital, that's super expensive. Because there's a vehicle involved and so on. If it's somebody who lives there, then I think it's much cheaper.
And there is sort of there is a behavioral change if they think that somebody's going to come and ask, or for whatever reason that does.
I mean, we found these survey effects, which was of a lot of interest and actually very disturbing from a social science perspective, knowing that your survey actually changes the behavior that you're trying to observe. I think that's a potentially quite severe problem for a lot of social science. So, which I didn't discuss today, but it's in the paper. But I wouldn't, if I were an NGO, I wouldn't take the lesson from that to be, let's actually do surveys or send in outsiders to do surveys. I would say, let's take the insight that personal contact matters, and let's try and arrange something so that if we can find a low-cost way to do it. And I mean, obviously, if you're running, it depends on the type of NGO. If you're running an NGO which is delivering a lot, if your partner's in health, then great, you can do the personal contact because you're doing the personal contact anyway. So just add this onto the message, some water safety and sanitation messages and hand washing, great. But if you're trying to create a nationwide program, it's the cost will, sending somebody around just to deal with water, it's not gonna be cost effective.
Local personal contact.
Yeah, I think if you can think about getting somebody who's already there involved, that's probably more cost effective.
Combined messages.
Yeah, maybe. Exactly. A community health worker incorporating this into the list of things, aside with malaria prevention, HIV prevention that the community health worker is doing. That makes sense.
The health clinic.
Yeah. Well, I think one great thing. I mean, I've focused on dispensers, but I think another very good strategy is have the nurse at the health clinic have a big supply of chlorine there, and hand it out to people when they bring the child in for immunization, when the child's born. That gets the personal contact and it gets the free supply. It doesn't have quite the convenience and habit formation and salience because that could just go in a corner somewhere when it gets home. But I think it's definitely worth looking into as well.
Do we have time for one more?
You were talking about how it might be more effective rather than building another borehole to spend that money to pay for chlorine over 20 years. Do you foresee at the end of that 20 years, people would be wealthier and they would have piped water, or this would continue, or kind of, do you see this as more of a filler technology or long term?
So, at some deep fundamental level, definitely a filler technology. And one thing that I think people in development haven't absorbed enough is just how quickly economies are growing. I mean, that's very clear in South Asia. But even in Africa, there's 5% economic growth rates. I think that it may not be 20, I mean, this particular rural area where people live on their farms instead of in villages, it's probably going to be more than 20 years till people get piped water. But I think this is a temporary, but maybe in 20 years they'll be able to switch to a system where there's what's called inline chlorination, where there's a pump and there's and the chlorine is automatically added at a dose that isn't going to make it taste bad. That's somewhat more expensive, somewhat more high tech, somewhat, it's a little bit harder, but that would be a better technology than these dispensers eventually. But dispensers is something that could be rolled out now, not everywhere, but to hundreds of millions of people. And I think so I think it's a stop. The short answer is this is a temporary measure, but for all the people who pass through ages 2 to 4, who are 1 to 4, who are dying of diarrhea, for them, they'll get past the critical threshold. So for them, it's critical to put something in place now.
Thank you very much.